Bismillahirrahmanirrahim. Assalamu alaikum everyone. I am Dr. Sidra Lodi and currently I am working as Assistant Professor of Medicine and Consultant Endocrinologist in King Edward Medical University. On behalf of Pakistan Society of Internal Medicine, I welcome you all to this 5th session of the Hypertension Course by PSIM. Joining us today are Professor Abdul Samad, our chair for today, and Professor Muhammad Hafizullah Khan Sahab, Professor Tariq Wasim, Professor Sajid Ubaidullah, Professor Azizur Rahman, Professor Amir Shaukat Sahab. I welcome all the panelists and all the attendees. With the permission of the chair, Dr. Abdul Samad, the man needing no introduction, the eminent cardiologist, teacher of teachers, the legend, I request to open the session formally. Right. Before going on, I will outline today's session. Today's session will have 2 modules. Both will be based on the treatment options. Today we will be discussing about the different antihypertensive agents and their characteristics. The first module will be about the non-RAS blockers, and the second will be about the RAS blockers. The outline, the session will be like this: that we will first start off.
First one is about RAS blocker presented by Professor Hafizullah.
Right, yes, sir. The first one is about the RAS blockers that shall be presented by Professor Hafizullah, and the second one is about the non-RAS blockers that will be presented by Professor Amir Shaukat Sahab. Each session will be 25 minutes of presentation. It will be preceded by a pre-test poll, and then we will have a question and answer session, a brief question and answer session. During the session, during the presentations, you can post your questions in the chat box that will be answered. Some of them will be answered real time in the chat box by our panelists. And later on, at the end of the presentation, we will take a few questions as well for the senior faculty and for the presenter. This will be followed by a post-test poll, and then we will move on to the next module. So our first speaker for today is Professor Dr. Muhammad Hafizullah. He is MBBS gold medalist, MRCP UK, FRCP Glasgow, FRCP Edinburgh, FACC USA, FCCI USA, FCPS Cardiology, FAPCS Japan, FECS from Europe, and FACP USA. He has served as Vice Chancellor of Khyber Medical University and as Professor and Head of Cardiology Department, Lady Reading Hospital. He was Project Director of Peshawar Institute of Cardiology since its inception. He has also served as Chief Executive of Lady Reading Hospital and Vice Team Research of PGMI. He has been President of Pakistan Cardiac Society, Vice President of Asian Pacific Cardiac Society, Japan, and the Governor of International Society of Cardiovascular Pharmacotherapy, Spain. In research, he has a lot of contribution. He has served as Chief Editor of Pakistan Heart Journal and the Chief Editor of Journal of Postgraduate Medical Institute. He has published more than 290 scientific articles nationally and internationally, and has authored 11 English and 4 Urdu books about preventive cardiology and social subjects. In addition, he has published more than 450 English and Urdu articles in leading newspapers as regular columns for creating awareness and highlighting social issues. Professor Hafizullah, please.
Thank you for this very elaborate. I think we should make it very brief next time. People start expecting high things from you when you have an introduction like this. Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wa halul 'uqdatam min lisani wa yafqahu qawli. My topic for today, given by Azizur Rahman, is different hypertensive agents and their characteristics. And I'm going to talk about RAS blockers. We all know blood pressure is a very common ailment. And the data that is the recent one comes from not from a cardiac society, but from a national diabetes survey of Pakistan. And what it tells us that blood pressure age adjusted is as common as 46.3, which means really half of the population that we see have got high blood pressure. Out of this, 24% were self-reported and 21% patients, 1 in 5, were hypertensive who did not know about it. It was equally common
Excuse
in
me,
urban and
Professor
yes,
Hafiz?
wait. Urban 46 and rural 46.8. In Punjab, it was 49, in Sindh 46, Balochistan 40, and KPK 33.3. So before we talk about this illness and the treatment regimens, let's take a poll about the questions that have been posted by PSIM. So over to you for the questions.
This is the last question. We shall be presenting the results, the pre-poll and post-test results at the end.
Okay, so I think, mashallah, the audience that we have are very well aware, and perhaps they don't need a long lecture, so I've cut down my lecture by half. To start with, I've told you the situation is very bleak because it is such a commonly prevalent illness. And on top of it, it is increasing, it is progressing. But the good news is, based on 600,000 patients, 123 studies, we found out that if we reduce blood pressure systolic by 10 millimeter of mercury, the benefits are immense. Like it reduces major cardiovascular event by 20%, coronary artery disease by 17%, stroke by more than quarter, 27%, heart failure, 28%, all-cause mortality, 13%, effect on renal failure in this study was not significant. Can you allow me to progress my slides, please? Okay. Now, I think it's important to understand right from the beginning that most of hypertensive, as I told you, are not aware, so they are not treated. And how many are they? Almost half of them. Now, in other half, the better half, those who are treated, blood pressure is not controlled in 35% of people. And blood pressure is only controlled in 17, and in some studies, 15, and in some studies, 5. So this is an illness, a disease, which is very easy to diagnose, but very difficult to control because basically it's a silent killer. So we have to make more efforts to actually find out what is happening to the patients. Important thing that blood pressure is not controlled, and a very nice study I want to present from Cobra BPS group, study based on Bangladesh, Pakistan, and Sri Lanka. And what do you see in this study? I cannot seem to advance my slides. Right, okay. So in Bangladesh, 55% of people were uncontrolled, which means 45% were controlled. In Sri Lanka, close to 55% people were uncontrolled. And overall, the impact was that it was uncontrolled in 58%. But in Pakistan, the situation was different. In Pakistan, as much as 70% of people in general population, the blood pressure was not controlled. So only it is controlled in 1 in 3. So we need to put in more efforts to know about this illness and control this illness. The factors that were in favor of not controlling: lower wealth index, single, more albumin ratio, reduced GFR, and of course, adherence to drug. Now, I think blood pressure we have to understand. It's a very sort of a very easy, but very difficult to understand and comprehend that blood pressure untreated leads to left ventricular hypertrophy. This left ventricular hypertrophy progresses to heart failure with preserved ejection fraction. And if untreated, it goes on to heart failure with reduced ejection fraction. Mind you, the morbidity and mortality in both these cases is worse than many malignancies. So we have to take it very, very seriously. Blood pressure, if not controlled, we know lead to all these problems. But if it is controlled and too aggressively, of course, it can cause this problem. But we, by effectively controlling blood pressure, by using proper agents, can control this thing. And one message that I would like to give from my talk today will be that blood pressure is not treating figures. Blood pressure is not treating figures. It is treating a human being with all its complexities. And to do that, what do you need to do? First of all, you have to have a very comprehensive history of all cardiovascular risk factors. It is inexcusable that you check blood pressure and you do not ask about their smoking status, obesity, diabetic status, and cholesterol. So you have to check up all these things and also do a thorough clinical examination to see the effects of hypertension in terms of effect on heart, kidneys, and everything. There are many guidelines now for hypertension. There are more than 14 guidelines, most popular being JNC. But most of these guidelines have got some consensus, and I would rather take you through that consensus than to take you through the guidelines. First thing is individualize the treatment. Every patient is different, so your treatment strategy should be different. We have got 4 classes of drugs: diuretics, CCB, ACE inhibitors, and ARBs. You can combine them or call them different class of drugs. So these are the classes of drugs that we can use to treat a patient. Long-acting drugs and single pill combination should be preferred because that increases compliance. Blood pressure should be controlled as soon as possible, because when it is controlled, it increases your compliance. Patient should be educated, and because this improves persistence, because patient, one, BP is controlled, he thinks the problem is over. So we have to tell them, no, the problem is not over, it has to continue. So we have to regularly monitor the patients. In most cases, multiple drugs will be required. Gone are the time that we used to use methyl dopa at all on its own. We will be requiring 2 drugs for most of the patients. When you're using 2 drugs, try to use single pill combination so that the compliance increases. ACE inhibitors and ARBs should not be combined together. The specific treatment recommendations and my rest of the talk will be based on those sort of things. So what I've discussed so far is that we should individualize treatment. We have got 4 classes of drugs that will be used, but we must simplify drug regimens, and we must be able to control blood pressure and educate our patient to improve persistence. Of the newer guidelines, we have the guideline from 2018 ESC/ESH guidelines, and then 2020 International Society of Hypertension Global Hypertension Practice Guidelines, and I'll be referring to these guidelines as you go along. The core drug treatment strategy, if I have to show you one slide, is that if blood pressure is increased more than 20 millimeter of systolic and 10 diastolic, you can use any combination. I'm not here to project ACE inhibitors or ARBs. All drugs are good. All drugs, we should know how to use them, and all drugs are equally effective as well. But ACE inhibitors and ARBs or CCBs or diuretics or these two can be combined. If blood pressure is not controlled, in spite of 2 drugs, you go on to 3 drugs. And if you have a resistant hypertension, that blood pressure is not controlled and demonstrated not to control, then you call it as resistant hypertension. In those cases, you think of either adding a diuretic, an alpha blocker, a beta blocker, or even spironolactone in a small dosages. So this is the basic theme on which we have to work. Between the ACE inhibitors and ARBs, we know ACE inhibitors are angiotensin converting enzyme inhibitor working on this. So it reduces the reduction of angiotensin 2, and it avoids 4 things: vasoconstriction, profibrosis, pro-inflammation, or ROS production, and PAI increase. So not only that it is controlling blood pressure, it is also affecting, modulating other things which favorably affect the target organ damage. And similarly, ACE inhibitors have the advantage that it also works on degradation of bradykinins, and it leads to almost all those things but are over here: vasodilatation, anti-fibrosis, anti-inflammation, anti-ROS, and anti-thrombosis. So as you can imagine, this class of drugs distinguishes itself from others, that it not only controls blood pressure, it also controls many other things. So I'll be discussing different groups of patients that in which what sort of a strategy we should adopt. We'll be looking at diabetes, CKD, coronary artery disease, CVAs, left ventricular hypertrophy, and COPD. Diabetes and hypertension is a bad combination. When this occurs, it predisposes patients to cardiovascular disease because it shares the same common risk factors. And it is interesting to see that most hypertensive will develop diabetics and most diabetics will develop hypertension in the due course of time. In the setting of a combination of this, it leads to arteriosclerosis, remodeling, fibrosis, inflammation, endothelial damage, leading to atherosclerosis, and then leading on to macrovascular and microvascular disease to cardiovascular disease. Diabetics have a double the risk of other people of developing vascular disease. Diabetes, 1/3 are already affected with the cardiovascular disease, and 50% of deaths will be because of heart problem. The good news, we know it's very bad, but we know that in diabetics, this is the study from UKPDS. We know that if you reduce blood pressure by 10 millimeters of mercury, remember when I showed you the figures earlier on, that was for the general population. Now we are talking about diabetic population. So it reduces complications related to diabetes by 12%, deaths by 15%, MI by 11%, microvascular complications by 13%. So very salutary effect in patients who are diabetics and hypertensive if you effectively control their blood pressure. And if you use better drugs, you probably will have better effects. I want to share over here with you this HOPE study and the two sub-studies called HOPE sub-study and HOPE 2 extension studies. HOPE study was a large, simple factorial design study by Salim Youssef. This was ACE inhibitors. Ramipril was used in high-risk patients, 55 years of age with evidence of vascular disease or diabetes plus one of the risk factors. So more than 55 and people with more risk factors. And HOPE sub-study was only on patients with diabetes, and HOPE 2 discontinued for about 7.2 years. So a long-term studies. And what do we see? Very interestingly, ACE inhibitors over here were shown to improve the primary outcome, which was MI, stroke, or cardiovascular, reduced by 25% with a very significant p-value. All-cause mortality reduced by 24%. And reduction of MI, 22%, reduction of stroke, 33%, and cardiovascular death by 37%. So in diabetes, when ACE inhibitors like Ramipril are used, the effects on the patient go beyond the control of blood pressure, and they have such salutary effects on everything, MI, stroke, and cardiovascular death. And some more interesting data that in HOPE study, and this HOPE 2 was the extensive study for 7.2 years, we see over here that these primary endpoints were reduced and the effect persisted even up to 7.2 years. And over here, it is reduced by about 20%, very effective. And very interestingly, for the first time, we found out that new onset diabetes could be prevented in as many patients in HOPE as 20%, and the same persisted for as long as 7.2 years. So what are the treatment strategies for patients in diabetes? The first thing is the goal of treatment should be below 140/90. And those in which we can control, it should be 130/90. And if target blood pressure should be 80, try to reach their 80 and not less than 70. And to achieve all these things, your best bet would be a RAS blocker, either an ACE inhibitor or ARB. If you can achieve it with that, this will be a class 1 indication, but you can also add to it a calcium channel blocker or a thiazide-like diuretic. So in diabetes, high risk group, your blood pressure level should be 130, and try to achieve blood pressure not less than 120, and RAS inhibitor will be a better choice of drug. Let's switch gears, go on to kidney disease. When it comes to kidney disease, most cardiologists will raise their hands and say, okay, we stop here. But it's very interesting to find that hypertension is a major risk factor for development and progression of albuminuria. And this sort of a thing will lead to all CKDs. A low GFR is associated with resistant hypertension and masked hypertension. What is masked hypertension? We know about white coat hypertension, in which blood pressure is high when patients come to our clinic or something to other scenarios. Masked hypertension is when patient has got a higher blood pressure at home and lower when he comes to the clinic, and these people have elevated nighttime blood pressures. So when patients have got renal problem, blood pressure becomes more difficult to control. The effects of BP lowering on renal function and albuminuria are besides and over and above than what you have got as cardiovascular effects. In this sort of a setting, RAS inhibitors are the first line of drugs because they reduce albuminuria in addition to blood pressure control. Others can be added if required. GFR, microalbuminuria, and blood electrolytes should be monitored in all these patients. Now, CKD is spreading like anything. Between the ages of 65 and 74, 20% men, 25% female, and above the age of 75, almost half of the population. And this is, of course, because of diabetes and hypertension. Angiotensin has a big role to play, is the main culprit in CKD, in causing it, in starting it, and then progressing. It increases proteinuria, it affects tubular transport, it affects the synthesis of nitrous oxide, it has got metabolic effects, upregulation of toll-like receptors, and induction of reactive oxygen species. So really, it works in more than one ways to increase CKD and progress CKD. RAS stimulation plus sympathetic activation, they lead to hypertensive nephropathy, ischemic nephropathy, chronic glomerular interstitial disease, and chronic obstructive nephropathy. So it leads to all these things through its acute and chronic effects. And not only that, it is affecting the cardiovascular things that we know of, like going from stage A to stage T. It is also at the same time affecting on kidneys as well, causing kidney damage, reduction in GFR, and kidney failure. So we should be very watchful and very careful about this. And over and above that, it causes heart failure, left ventricular hypertrophy, ventricular arrhythmias are quite common in patients with this renal failure. Now, what are the practical considerations that I would like to discuss? One is, at what level of eGFR is it safe to use ACE inhibitors or ARBs? Now, all patients with CKD should be considered for pharmacological treatment to slow down the progression. And how about ACE inhibitors? ACE inhibitors can be continued with first grade, second grade, and third grade. In fourth and fifth grade, it is controversial. So if I can remind you, first grade will be from 90 to above GFR, second grade 60 to 90 of GFR, and third grade will be 30 to 60 GFR. So up to 30 ml per minute of GFR, you can use ACE inhibitors and ARBs confidently. Below that, one should question mark. How about checking potassium? So if your GFR is 60 ml plus, then every 6 months, but if it falls down to 30 plus below, then from 30 level, then it should be every 3 months. So lower the GFR more frequently, you should be checking renal functions. With careful monitoring, most patients with advanced CKD can continue to take ACE inhibitors and ARBs. Effects of RAS inhibitors, I just explained before, but they are very effective in protective role in different stages of kidney disease. This is through 4 mechanisms: reducing blood pressure, reducing proteinuria, decreasing the decline of renal function, and of course, preventing occurrence of peritoneal fibrosis. So working through these 4 things, RAS blockers are very effective in controlling blood pressure. Based on 17 randomized trial, recruiting 17,000 patients, it was shown that ACE inhibitors and ARBs reduce protein levels, one, control blood pressure, and both ARBs and ACE inhibitors were effectively controlled, equally effective. From this, we learned that both ACE inhibitors and ARBs have been shown to reduce albuminuria levels. An interesting thing is that initial reduction in albuminuria during RAS inhibition with associated with long-term renal protection. So when your proteinuria reduces, you protect your kidneys, and larger the reduction, more the protection. So you should be looking at albuminuria, monitoring albuminuria, and trying to reduce it. And this is a very nice, interesting slide. This shows over here as level 1, and sorry. So anything below this will be reduction, improvement of renal function, and this shows albuminuria over here. Blue are ARB or ACE inhibitor trials, red are ACE inhibitor trials, and calcium channel blockers over here. So it shows that when your albuminuria is reduced, going down to 30–40% in drugs with ACE inhibitors or ARBs, your renal function also improves. In one study that we have, it perhaps did not affect the renal functions that effectively. So what are the guidelines for treatment of hypertension in CKD? First, control blood pressure, bring it below 140/90. And if possible, below 140, between the range of 130/140. And in these cases, individualize your treatment. And this should be regulated by tolerability of the drug and its impact on renal function and electrolytes, which means in patients with CKD, you must be monitoring their renal function and you must monitor their electrolytes. RAS inhibitors, blockers are more effective at reducing albuminuria than all other drugs. So they really appear as the drug of choice in patients with CKD. Other combined drugs may be combined when it is difficult to control the blood pressure. Let's go on to coronary artery disease. Now, we all know that there's a very strong epidemiological interaction between CAD and hypertension. More hypertensives will develop CAD and so as AMI. Now, what happens in this sort of a thing? Let me take you through the studies. There have been lots of studies, and these are the studies when I was young, and I'm not young anymore. And it starts with consensus trial, SAVE trial, AIR trial, JC, ISIS-4, TRACE, SMILE. These are the time when we did not have any thrombolytics or angioplasty, and patients were put after MI in the CCU beds. So these trials showed us at that time that using ACE inhibitors reduce mortality. The very famous SAVE trials in which mortality was reduced by 19%. Then a ramipril trial called AIR trial, mortality reduced by 73%. Then another, if you combine SAVE, AIR, and TRACE all together, mortality reduced, odd risk reduction by 0.74, which is 26%. And after this, ARBs were trial, optimal study for losartan, Valiant for valsartan, and that also showed us that ACE inhibitors plus ARBs almost had similar effects. So both the classes of drugs had similar sort of effects after acute myocardial infarction. So the recommendation is that RAS blockers should be started as early as possible and continued indefinitely. We do not stop it. Blood pressure must be monitored. We are not here to control blood pressure. We are here to make sure that blood pressure is monitored properly. And of course, ACE inhibitors and ASRBs should not be combined. Very importantly, RAS blockers recommended as standard medical therapy in patients with AMI who are at high risk. And who are the people at high risk? Who have heart failure, who have low ejection fraction, who have got diabetes and CKD. So this is the high risk group in which you must use ARBs or ACE inhibitors. And also, it is recommended that in patients who are not at high risk, even then, these patients will benefit, those with the normal ejection fraction, well-controlled cardiovascular risk factors, even in these patients, your ACE inhibitors will improve. So as per guidelines, all patients with a history of myocardial infarctions, beta blockers, and RAS blockers should be used, more so in patients who have got reduced LV fraction and who are at high risk. So in patients who have got CAD and you've got hypertension, the target is not 140, but 130, and if tolerated, go to up to 120. In older patients, you can go up to 130/40. Target of blood pressure diastolic is 80. So in patients who are hypertension with a history of infarction, beta blockers and RAS blockers are the ones which should be used. This is a class 1 indications. So even if the setting of CAD in patients who have got symptomatic angina, then beta blockers or calcium channel blockers may be used. Now we all know about this cardiovascular disease continuum leading to end-stage heart disease. This starts from something called as endothelial dysfunction. And endothelial dysfunction arises from all these risk factors which causes endothelial injury, and this leads to inflammation. Affected by this, it leads to either atheroma or thrombosis, leading to ACS and death. ACE inhibitors have got a wealth of data. No other drug has been studied so intensively and so richly. So we have got this in red, which people with post-MI, with heart failure, with reduced ejection fraction. These studies showed the beneficial effects of ACE inhibitors. Those of us who were involved in this, soft prevention showed us that people who had reduced ejection fraction but no heart failure also improved their outcome with ACE inhibitors. Then HOPE study I just discussed with you, high-risk patients who had got more risk factors improved with this, and Europa was a study in all CAD patients. So we see through the continuum of all these CAD, right from endothelial injury, when stable coronary artery disease with infarction, all of them benefit from ACE blockers. We change the gear now. Heart failure. We all know hypertension is a risk factor for development of heart failure in both reduced ejection fraction and preserved ejection fraction. Outcome is worse and mortality is increased in hypertensive patients. And it has been shown that hypertension reduces incidence of heart failure and heart failure hospitalization. RAS blockers, beta blockers, and mineralocorticoids, this is one of the questions, have been shown to improve the clinical outcomes in patients with reduced ejection fraction. Lately, angiotensin receptor blockers plus neprilysin blockers, sacubitril, has been shown to be of great advantage in patients with reduced ejection fraction and also recommended by patients for preserved ejection fraction. So at right now, ACE inhibitors, the use of ACE inhibitor is beneficial for patients with prior or current symptoms of heart failure, ARBs in patients who cannot tolerate ACE inhibitors, but now ARNI is recommended for chronic symptomatic heart failure class 2 or 3 who can tolerate an ACE inhibitors. As a matter of fact, the new recommendation has come that sacubitril valsartan rather than ACE inhibitors or ARB should be utilized in patients with new onset heart failure or decompensated heart failure. And we don't need to check on anti or pro-BNP. So it is highly supportive that you use sacubitril valsartan in hospital initiation of sacubitril valsartan after an acute event, even in patients who have not been tried on ACE inhibitors or ARBs. So what are the recommendations? Recommendations in patients who have got left ventricular hypertrophy and heart failure is to reduce blood pressure to 140/90. In patients with reduced ejection fraction, it is recommended that we should use an ARB, a beta blocker, and a diuretic. And in preference to it, we can add sacubitril valsartan. Patients with preserved ejection fraction, the threshold, the target, and the treatment modality is the same. And something which is very close to my heart and something we should be really looking for, just trying to pick up, is left ventricular hypertrophy. In the setting of left ventricular hypertrophy, the treatment of choice is RAS blocker, and we must use RAS blocker very effectively in this sort of scenario. My last two points will be hypertension and previous stroke. If the data of hypertension, if you look at, it is perhaps most significant and more sort of effective, and it has got the best numbers for the treatment of stroke. So hypertension is the most important risk factor for stroke. And the good news is stroke can be largely prevented by blood pressure control. And this can be achieved by reducing the blood pressure. And I would go that we should all know how to treat stroke, whether it's an acute intracerebral hemorrhage or ischemic stroke, to bring the blood pressure down, but not very down, and bring it down slowly. And in patients who have had stroke, we should try to aim to bring their blood pressure down to 130/20. And for this sort of drugs, perhaps a RAS blocker, a combination is the best treatment of choice. And this is class 1 indication in the setting of those patients who have got stroke. Last to discuss will be COPD. Cardiologists and pulmonologists do not get along very well, unfortunately, but hypertension is the most frequent comorbidity in COPD. So in this class of patients, we should try to bring their blood pressure down to 140/90. And in this class of patients, the treatment of choice will be an angiotensin ARB blockers. You can use CCB or diuretic, but the drug of choice will be an ARB in this sort of a thing. In the flow of my talk, I may have tried to portray that we have conquered blood pressure and we have been able to control. There are still 5 big challenges that I would like to leave you with when you before I finish the talk. First, we have been miserable in controlling blood pressure, hardly 30% or even less than that. The current strategies have not been able to affect atherosclerosis and end-stage renal disease. We have advanced, but we have got a long way to go. Think of all the anti-obesity drugs. They all lead to hypertension. So there is something to do with obesity and hypertension, and we should be able to do better to control obesity and to control the heart failure. So my take-home messages for you will be, hypertension is on the rise. I've showed it to you. And when we control, we do not control figures, we control a whole human being. What does that mean? It means detailed history and examination, assessment of proper cardiovascular risk factor, and we should know when to treat and what are the targets to treat. And very importantly, individualized treatment. And as I just said, that in majority of patients, blood pressure is not well controlled. And think of these challenges. And these challenges are very important, that we have not been able to make a dent on these things. So we have to develop a new attitude about blood pressure. We should start thinking beyond the numbers. And what I've tried to talk about is that ACE inhibitors and ACE ARBs are effective first choice of drugs in most scenarios. Effective in diabetic hypertensives to prevent progression of endothelial damage, kidney damage, prevention of stroke, preventing in renal disease, very effective in delaying the progression of CKD, very effective in CAD, right from prevention of CAD to prevention of stable coronary artery disease, AMI, preserved ejection fraction, and reduced ejection fraction. The only drug to show very effective results in left ventricular regression and still not very effective. Big role to play in prevention of heart failure, progression of heart failure, and reduction of hospitalization. Very important to prevention of strokes and effective in the setting of COPD. I just tried to show you that it is very effective drug, not negating other drugs, but this is one drug जिससे आपने दोस्ती करनी है, इसके बारे में सीखना है, or you should learn how to effectively use ACE inhibitors and ARBs. I thank PSIM for giving me this opportunity. to talk to about 200 plus people. Thank you very much.
That was brilliant, Professor Hafizullah. Very, very eloquent and very, very elaborate. I think attendees must be very, very well now informed. Thank you.
Thank you, sir, for such a brilliant and engaging session. We will now take some questions from the attendees. Kindly type in your questions if you would like to speak, kindly raise your hands.
Sidra, I think we have to run the post-test poll now.
Right, sir. So before that, we will go for the post-test poll. The attendees the participants are requested to kindly fill this in so we can move on. Right, so we are done with the poll and we will take questions now. The question was posted by Dr. Muhammad Awais Qadri. He has asked, can we use ACE inhibitors and ARBs in patients with stage 4 diabetic nephropathy having type 4 renal tubular acidosis? Professor Shahbaz Qureshi, if you could please take the question.
I think I discussed that in up till level 3 CKD, we can use ACE inhibitors and ARBs. But in class 4 and class 5, when the renal failure is bad, I think we should leave it to the nephrologist to choose the drug of choice in those patients. So I would not recommend an ACE inhibitor or ARB in class 4 and class 5 when the renal function are below 30 ml of GFR.
Right, sir.
I think the nephrologists,
normally,
if they are on the renal replacement therapy, they can still use the ACE inhibitors and ARBs if they are on renal replacement therapy.
So we leave it to the nephrologist.
Can I just make a comment about it?
I'll have some comment, please.
Normally, when we are talking about the use of RAS blockers in patients with CKD, initially there is going to be a rise in serum creatinine in these patients, which shows that it is being effective. However, if the increase is more than 30%, then you will not use RAS blockers in these cases. You would then use other drugs for that. And I think as Professor Azizur Rahman very rightly pointed out, those patients who are on renal dialysis or end-stage renal disease on renal replacement therapy, these are the patients who can actually take the RAS blockers because they are already on dialysis.
Right, Dr. Anwarul Haq is asking about the cutoff values of creatinine and urea levels to stop ACE and ARBs. And
if from the baseline the increase is more than 30%, if from the baseline the increase is more than 30%, then you stop it.
Right. So there's a question by Dr. Tariq Masood. He's asking, are all ACE inhibitors equally effective
Dr.
in control
Sidra.
of protection of CKD? Yes, sir.
Dr. Samad sir wants to say something.
Yes.
ये जो ACE inhibitor हैं, ये जब शुरू में आए तो इनको हम we used to check renal artery stenosis with the use of ACE inhibitors, because if you give it in renal artery stenosis, the creatinine and urea is going to go very high. And this was a test used whether a patient is suffering from renal artery stenosis or not, and then the other test used to be done. And I think even now when you start ACE inhibitor, as Dr. Shahbaz Qureshi said, you should check his creatinine after maybe a week or so. If it is going up, most probably this patient is suffering from renal artery stenosis, and this is why otherwise the effect of ACE inhibitor are to reduce the urea or the creatinine and improve the renal function. But if the patient is suffering from renal artery stenosis, then patient will have an increase primarily in these two indicators of kidney function. So I think this issue, because now these drugs are very commonly used. So I think when it is commonly used, people are not very careful about their effects and side effects. So I think once you start this drug, in a week time, you must check his creatinine. And if you as he said, more than 50% increase, we must stop it because this person is suffering from renal artery stenosis, and maybe it is advisable to check him for a renal artery stenosis further, whether he actually has a renal artery stenosis. Because if he has renal artery stenosis, you put a stent in the renal artery, probably you will avoid a lifelong medical treatment.
It's very interesting to note that when ACE inhibitors were introduced, and I remember I take you back to 1983, when we would be giving them ACE inhibitors, especially captopril, we will give patient albustics to check up urine proteinuria. And at that time, it was thought that perhaps the side effects of ACE inhibitors are proteinuria and loss of taste. So we'll be looking for these two things. And look, the times have changed where the same group of drug is being used for proteinuria. This is one of the paradoxes of medicine. Next question.
Thank you for the insight, sir. We have a question about the use of ACE and ARBs in gouty arthritis and about the percentage of cuff incidence with ACE inhibitors. After that, we will be moving on. The incidence of cuff with ACE inhibitors, and can we use these ACE, and I'm actually combining two questions due to shortage of time, in gouty arthritis.
Whom do you want to answer? Right, in cases of cough, I think cough is something, Samasab has got many stories to tell us about that, but yes, cough is there, and this cough is intractable. If you look at different studies, it varies from 5 to 15%. The interesting thing is that when you combine the same ACE inhibitors with a calcium channel blocker or a diuretic, the cough incidence goes down markedly. Rarely, you also have cough with ARB as well. So in ARBs, at least 2% of patients will develop cough. So this is something you must be aware of and must be able to take care of it as the time comes along. The second thing is ACE inhibitors will not affect the gout in itself. It is the diuretic component, especially the thiazide diuretics, which increase in uric acid and cause gouty arthritis. Thank you.
Actually, when we are talking about gouty arthritis, I think the questioner wants this to be mentioned, that with the use of ACE inhibitors and the ARBs in combination with diuretics, because diuretics actually increase the uric acid level. But when you combine it with the RAS blockers, the uric acid level does not rise. And so the reason for that is the ACE, and if you look at the corollary for that, ACE inhibitors or the ARBs, they actually do not increase the incidence of gout. Let's put it this way.
Yes, ACE inhibitors, ARBs do not increase gout, but diuretics, thiazide diuretic, that is why many people recommend indapamide, which is a thiazide-like diuretic, which will not increase uric acid. Thank you.
And one of the actions of losartan is actually to lower uric acid.
All ARBs.
Yeah, that is specific for losartan.
Yeah, that's. Now let's move on to the next step. Please pause. We have to show you the comparison of pre and post-test polls.
Kindly show the comparison.
Although I think people actually performed very well, even Professor Fizullah, please comment on the results.
I think people, mashallah, you got a very well-aware guidance, audience. And I think the results are extremely good. From 64%, we increase up to 89%. So I think my contribution is only about 15%. That's wonderful.
A big one.
Well, I mean, this was a very, very easy sort of an MCQ we made. So that is why perhaps it did not have the discriminatory index in that. So 84 to 94 increased by 10%. Okay. Third. 85 to 97%, increased by 12%. Okay, again, it was all very clear, and those who did not know it, मुझे लगता है इन्होंने शरारत की है और जानबूझ के थोड़ा सा, या शायद अजीज साहब ने थोड़ा सा गलत आंसर दे दिए थे ताकि ये ऐसे, it should look good later on. And the last one, this is impressive, from 90 to 96%. So, I mean, many ACE inhibitors would like you to believe that cough does not occur. It does occur, it is common, and we should be aware of it. Samad Saab tells a story about this cough, that cough is very important part of it, especially when he was in King Edward's Medical College.
Thank you, sir. Thank you for your contribution. And I would also like to thank the participants that they have come prepared for the session. Thank you for this engaging and stimulating session. We would now be moving on to the next session, the next component of today's session. The topic is the antihypertensive agents, the non-RAS blockers, that are to be presented by Professor Dr. Amir Shaukat, who is MRCP from UK, FRCP UK, FCPS Medicine. He is currently Professor of Medicine and Head of Medical Unit 2 at Allied Hospital and Deputy Dean, Punjab Medical College, Dean Postgraduate Sciences, Faisalabad Medical University, as well as in charge of COVID-19 management team at Faisalabad Medical University. Professor Amir Shaukat, please.
Right. Bismillah ar-Rahman ar-Rahim. I hope that I am clearly being heard and you can see my presentation. Okay?
Please, sir, please.
Right. So my task is actually absolutely different from what Professor Hafizullah Saab presented just about in the earlier part. And I must congratulate him for his splendid presentation. He is an excellent speaker, and I'm a big fan of his work and whatever he's been doing previously. And I'm honored, and I think it's a point of proud distinction for me to be speaking in front of mentors like Professor Samad Saab, Professor Rizur Rahman, and I'm a proud member of PSIM. And this is the institute that I belong to. Faisalabad Medical University, as you know, is a premier medical university, and you would be pleased to know that it is one of the biggest medical university in all Pakistan. We've got 3 tertiary care hospitals attached with Faisalabad Medical University. And via this presentation, I would take the opportunity to invite all of you, if possible, to come and pay a visit to us. And it would be indeed a point of honor for us. So
for your kind invitation, I would request you to pause for a moment. We have a pre-test poll coming up. Participants are requested to kindly answer the questions. There are 4 in all. And sir, I would also like to take this opportunity. During the first presentation, there were several questions about beta blockers and calcium channel blockers. So we would be bringing them to you.
I intentionally did not contribute in those questions because I thought that once we go about these questions being put to you via PSIM, I think it would address most of our issues that we were dealing with in the previous part.
Right, sir. We have also requested the participants to hold on for a bit and wait for your presentation. I hope by the end, most of the things will be answered.
I hope so, yeah.
Right, sir. I think we are done with the poll. No. Right. The poll is, question 4 is in progress. Right. And that was the last question for this poll. So kindly carry on with your presentation.
Right. Thank you very much. As you can say, and you can see by my topic, I would be talking about the slightly forgotten and the older agents for the control of blood pressure. And this is by no means to say or undermine their capability in controlling blood pressure. ACE inhibitors, ARBs, and RAS blockers are very much in fashion now. A lot of data behind them as well. And Professor Hafizullah has very nicely talked about their mode of actions and their characteristics, their benefits. So my task is to educate you about the forgotten agents of control of blood pressure and the various indications in which they can probably be used to control blood pressure. So, whenever we come across and we want to make a regimen of controlling blood pressure, it should never be complete without the non-pharmacological measures. They should be offered to all patients with hypertension, even on medications, and may be used alone in patients with high normal blood pressure or grade 1 hypertension. Weight control, exercise, dietary measures, sodium restriction, alcohol cessation, stopping smoking, meditation, dietary supplements, we all know is very important in making any management plan for the control of hypertension. You can see by this slide that the impact of all of these dietary and lifestyle modifications that it has on the systolic blood pressure, maintaining a normal body weight of less than 25 body mass index has an impact of 5 to 10 drops in systolic blood pressure. Dietary changes in which you use high fruits and vegetables and low in fat diet would have an impact of approximately 10 to 15 millimeters on systolic blood pressure alone. Decreased sodium, loss of stopping alcohol, and exercise, as you can see here, has got a tremendous impact. So it is to tell you that lifestyle modification and sticking to a diet plan is so very important and should never be forgotten in making any management plan for the control of hypertension. Pharmacological measures, rotate against or across with the various guidelines that we have the benefit of over the past 20-25 years. But whenever you choose or you consider blood pressure level before treatment, you make a sort of a regimen in which you find out if there is presence or absence of target organ damage, and you bring it into the account the various risk factors. And then you are supposed to choose between a single agent at a low dosage or a true drug combination at a low dosage. If you choose or you start off with a single agent and the goal blood pressure is not achieved, then you go and switch to a different agent at a lower dosage. And if the blood pressure goal is not achieved, then you would go to a 2 to 3 drug combination. Similarly, in a 2 drug combination at a low dosage, you would either escalate the dose or then add a third drug at a low dose, and you would go with a 2 to 3 drug combination. This is what we usually do. Now, there is a complex and a picture in which every physician is confused because he's bombarded with a lot of agents, despite ACE inhibitors and calcium antagonists becoming part of the #1 recommendation of all guidelines, and diuretics also recommended as #1 therapy for the control of blood pressure. By no way beta blockers have lost their ground, and if you come across the prescriptions of primary physicians, we still find that beta blockers are preferred choices of drugs used for the control of blood pressure. But these are the various agents available at hand to us for the control of blood pressure. The Birmingham hypertension square for add-on or add-in drugs in the management of hypertension is given here. This square may be approached from any corner, as you can see, with first-line drugs chosen logically, and the optimal second-line agents are immediately adjacent and are indicated in arrows, which means that after the non-pharmacological advice and whatever we've talked previously, you can choose and you can switch between all of these agents given here, meaning thereby calcium antagonists, ACE inhibitors, Arbs, thiazide diuretics, beta blockers. So this would slightly simplify things for you. All drug classes of blood pressure have almost the same efficacy as they've been proven by the various meta-analysis. The choice, however, depends on age and the presence of comorbid factors, and kindly start with a low dose of a long-acting drug and then titrate a dose. The treatment of systolic and diastolic hypertension without other compelling factors is given here. You can see here that after lifestyle modification, you need to, and you want to bring the target blood pressure to less than 140/90. These are the various agents that are available for you for doing it. The thiazide diuretic part 1, the ACE inhibitors, the Arbs, long-acting calcium antagonists, beta blockers. A combination of the two first-line drugs may be considered as initial therapy if the blood pressure is more than 20 millimeters of mercury systolic or more than 10 millimeters diastolic above target. So you won't go for a monotherapy in that case, and you would begin off straight away with a double drug combination. So what to choose then, a single drug or a combination therapy? The monotherapy, all meta-analysis have taught us, they reduce blood pressure by about 4 to 8%. Appropriate drug combination lowers blood pressure by 8 to 15%. However, as we have learned over the past, and now we have got a consensus over it, and all of our colleagues now have made a habit, we use a combination therapy because it is more effective as compared to a monotherapy, particularly in our circumstances. It is beneficial to add small doses of a second drug rather than increasing the full dose of the first drug. So this is what we have learned over the past 10 to 15 years, that a double drug combination fares better as compared to a single drug for the control of blood pressure. But everybody is confused. When to add a diuretic? When to start off with an ACE inhibitor? Should we put the patient on a calcium blocker? Is an ARB blocker better than an ACE inhibitor? What about where to add and when not to add a beta blocker? What is the role of an alpha blocker? Patient is confused, doctor is confused, and but the logical answer is that most hypertensives will need to be controlled with more than 2 drugs, and drug combination may be synergistic. The various agents available again, so as to summarize what I'm bringing up my topic to, is diuretics, alpha receptor agonist, alpha 2 ones, calcium antagonists, and ACE inhibitors, etc. So what should be the ideal blood pressure or the ideal antihypertensive? Should be a drug which has got no contraindications, should be cheap, should be effective as monotherapy, should have a single once daily dosage. It prevents and reverses target organ damage, improves mortality and morbidity, has got no side effects or adverse metabolic effects, and you can combine it safely with other agents. So by this, this is the target given to me. The choices that we would discuss here are the drugs not included in the list of ACE inhibitors or the Arbs, and the agents that we have for this particular purpose include thiazide diuretics, beta receptor antagonists such as propranolol, etc., calcium channel antagonists such as nifedipine, amlodipine, the centrally acting agent drugs such as alpha adrenoreceptor agonists, clonidine, methyl-dopa, alpha-1 adrenoreceptor antagonist, prazosin, vasodilator drugs, that is calcium channel activators such as minoxidil. All of these drugs are available in the market, and some or the other we've forgotten these drugs, but by no means they're not being used. And I think once we are through this presentation and we have this interaction in the end, we will be more learned to when to use them judiciously, logically, and with the data behind us. So this is a regimen to tell you that the various agents available at hand to us for the control of blood pressure include diuretics, sympathopelagic blockers of the CNS sympathetic outflow at the ganglia level, at the nerve terminal level, the alpha or beta receptor blockers such as prazosin. Then we've got at hand available vasodilators, including the older ones, then the calcium antagonist, and the parenteral vasodilators such as nitroprusside, and is the angiotensin receptor blockades, and the renin inhibitor, the direct ones. So this is a slide that will tell you how the blood pressure basically increases. You know, it's a response mediated by 2 things. Given above is the response mediated by the sympathetic nervous system, and given below is the response mediated by the renin, angiotensin, aldosterone system. That both go hand in hand as far as the blood pressure mediation is concerned. Whenever you would have increase in blood pressure, it would be mediated initially by an increased sympathetic activity. This activity leads to activation of beta-1 receptors in the heart, activations of alpha-1 adrenoreceptors on smooth muscles, which leads to increased cardiac output, increased venous return, increased peripheral resistance, and then it has an effect on the activation of beta-1 adrenoreceptor on the kidneys. The renal action goes through the renin, angiotensin, aldosterone axis, increased aldosteronism, aldosterone levels, increased blood volume, increased salt and water retention, and which in the end leads to increase in the blood pressure. So this is again the target, the organ or the target drug targets for controlling the blood pressure. You know, blood pressure affects every part of the body, and when you intend to use an agent for the control of blood pressure, and you want to bring out an agent which has got a logical effect, you need to know that these are the various parts of the body at which we've got a lot of agents available that can act on these levels. For example, at the vasomotor center, we've got the benefit of having methyl dopa with us and clonidine with us. Then if you want to have a problem in which you want to address the sympathetic nerve terminals, then you've got the benefit of having guanidine with us. If you want to act on the heart, then you have got the benefits of having the propranolol and other beta blockers. Then we've got the advantage of adding alpha receptors at the level of vessels. And then we've got various agents which are acting at vascular smooth muscle level and which cause a vasodilatory response. And obviously the drugs that help you to protect the kidneys in the initial part. And when you've got advanced kidney damage, you've got other agents available as well, which you can use for the control of blood pressure. So you can see by this slide that we've got a lot of antihypertensive agents available to us, apart from ACE inhibitors and Arbs, which can be used at various levels for the control of blood pressure. But before using them, you need to address the patient's complaints, take a detailed history, and then address his amount of kidney damage, heart failure, brain damage, target organ damage, and then you come up with a strategy of which agent to use and why to use. Diuretics are still very much in fashion. The ones that we've got available to us are thiazide diuretics, lube diuretics, and potassium-sparing diuretics. They are currently recommended as the first-line drugs, the thiazide ones particularly, for hypertension, unless there are compelling reasons to choose another agent. A low-dose diuretic therapy is safe and effective in preventing stroke, myocardial infarction, and congestive heart failures, all of which can cause mortality. Recent data suggests that diuretics are superior to beta blockers in the older age groups. Thiazide diuretics mechanics you can see here have been found to be the most widespread in use. The thiazide diuretics decrease blood pressure in both supine and standing positions. These agents counteract the sodium and water retention observed with other agents used in the treatment of hypertension, example hydralazine. And thiazide diuretics, they lower blood pressure initially by increasing sodium and water excretion. As you can see here, the effects of thiazide diuretics on the right side is given. They decrease sodium and water retention, they decrease blood volume, they decrease cardiac output and peripheral resistance, and thereby help decreasing the blood pressure. That is why it still remains to be a very good choice in the initial part for the control of hypertension. Thiazide diuretics are also beneficial because they are cheap. They can be used in combination with beta blockers. They can be used in combination with ACE inhibitors. Thiazide diuretics are useful in the treatment of plaque or elderly people both. They are, however, not effective in patients with inadequate kidney functions, as has been discussed previously. In patients who've got a creatinine clearance of less than 50, lube diuretics would fare slightly better. The potassium-sparing diuretics is used with thiazides. Obviously, you can use them, but the spironolactone part has the additional benefit of diminishing the cardiac remodeling that occurs in heart failure. So if you are coming across a patient in which you've got kidney damage going on, then you would prefer a lube diuretic over a thiazide one. If a patient has got a heart failure going on, then you would choose a potassium-sparing diuretic over a lube diuretic again. But in the initial part, as taught earlier, if you want to have a drug which is safe and can be combined with other agents, then you would probably choose a thiazide diuretic. The adverse effects of thiazides have been discussed by my fellow colleagues and teachers, and we've talked about the various issues that can happen if you don't know if you are using it logically or not. Hypokalemia, muscle pain, fatigue, hyperglycemia because of the inhibition of insulin release due to the potassium depletion can sort of perpetuate or go up with the usage of thiazide diuretics. Then you have a problem of hyperlipidemia. You might have a rise in the total LDL levels. Hyperuricemia, is a well-recognized factor, should not be used in patients of hyperuricemia. Sudden cardiac death if the patient goes into hypokalemia because of ventricular tachycardia, as enterositis depointis. All the metabolic issues usually have been seen with the higher dosage of thiazide diuretics. That is why we recommend that they should be used at a lower dosage, and the dosage available of the thiazide diuretics or the ones that we recommend is the one at a lower dose, that is from 12.5 to 25 milligrams. And with this, the average for this blood pressure is the same with other antihypertensive agents that would be close to 10 millimeters of mercury. So the current status is that the effects of low dose of thiazide diuretics overweight side effects. There is no significant problem of hypokalemias with the lower dosage. There is very low incidence of arrhythmias, and there obviously would be lower incidence of hyperglycemia, hyperlipidemia, and hyperglycemia, and reduction in myocardial incidence, that is reduction in mortality and morbidity. JNC recommends low dose of thiazide diuretics in essential hypertension. It preferably should be used with a potassium-sparing diuretic as a first choice in the elderly. If therapy fails, then you can safely combine it with another antihypertensive agents. But when you've got heart failure or kidney disease going on, then the other diuretics obviously have got better effects as compared to a thiazide diuretic. The loop diuretics part, they act promptly, even with patients with poor renal function and who have not responded to thiazides or other diuretics. Loop diuretics cause decreased renal vascular resistance and increased renal blood flow. So it's an obvious choice for those patients in which you've got compromised kidney functions. The adverse effect of loop diuretics include hyponatremia, hypomagnesemia, hypocalcemia, hyperuricemia, hyperglycemia, hyperlipidemia, etc. So the potassium-sparing diuretics are the ones who've been studied, and Professor Fizullah would be much more better equipped than me to talk about the benefits of potassium-sparing diuretics, because it remains to be the ideal choice for patients who've got a concomitant heart failure going on. They are inhibitors of epithelial sodium transport at the distal, at the late distal inflecting ducts. Spironolactone and other aldosterone receptor agonists reduce potassium loss in the urine. Aldosterone antagonists have the additional benefit of diminishing the cardiac remodeling that occurs in heart failure, and potassium-sparing diuretics are sometimes used in combination with loop ones and thiazides to reduce the amount of potassium loss induced by those diuretics. Their adverse effects to be kept in mind is the hyperkalemia one, which is more important. So beta blockers by no way have lost their track. They remain to be a very good choice in patients who've got a concomitant coronary going on. And the beta receptors obviously are the one also which have got an effect on decreasing the renal levels. So not only that they inhibit the activation of beta-1 renal receptors on the heart, they also help in lowering the renin levels. And by causing a decrease over and decreasing the renin levels, they obviously have an impact on the renin angiotensin aldosterone axis. But by the activation or decreasing the activation of beta-1 receptors in the heart, they have an effect on cardiac output and peripheral resistance, to remain to be a very good choice to be added in certain circumstances when you've got a sympathetic overdrive going on, or in patients who've got an anxiety disorder with them, patients who are thyrotoxic and have hypertension. So they still remain to be a very good choice in those patients in which you've got hypertension with a fast heart rate, or a hypertension, the white one, or the masked hypertension, or the white coat hypertension, or the ones in which you've got sort of a anxiety factor going to it as well. So these beta blockers, are the non-selective ones. You've got the benefit of now we have the selective beta blockers, and we've got beta blockers with alpha blocking activity going on as well. The non-selective ones are the ones who have an intrinsic sympathomimetic activity, and the ones who don't have it. And so obviously you can choose between all of these agents available to us. This graph tells you and gives you all the options which can be used for the various indications at the various stages of blood pressure. Beta blockers are orally active. The beta blockers may take several weeks to develop their full effects. Beta blockers are more effective for treating hypertension in white than in black patients and in young compared to elderly patients. Conditions that discourage the use of beta blockers obviously is when you've got a COPD, a chronic congestive heart disease, or a severe symptomatic occlusive peripheral vascular disease. That is a problem that is found in the elderly and in diabetics. Hypertensive patients with concomitant disorders such as the beta blockers that will be useful in treating conditions that may coexist with hypertension, such as SPTs, previous MIs, angina, chronic heart disease. But this is again for you to decide at which stage of the disease these agents are to be used. Adverse effects, are hypotension, bradycardia, fatigue, decreased sexual dysfunction, decreased libido, etc., and etc., but should never be used in patients of acute heart failure or asthma. Calcium channel antagonists, I want to discuss with you. This is obviously one of the agents which has been used as a first-line drug according to all guidelines, and the various calcium channel blockers available in the market include the phenylalkylamines, the benzodiazepines, and the dihydropyridine group. The more popular these days is the dihydropyridine group, which is of 3 generations. The first one was the nifedipine one. The second one, not available in Pakistan over here, but amlodipine, we've been bombarded with it. And amlodipine is a very safe drug to be used. However, the problems with amlodipine is that it cannot be used in patients, or should not be used in patients with a high renin activity or a high sympathetic drive. You've got the benefits of having verapamil and diltiazem, which can be added to various indications that I will be discussing in the next slide. Calcium antagonists are recommended when the preferred first-line agents are contraindicated or are ineffective. They are effective in treating hypertension in patients with angina and diabetes. High dosage of short-acting calcium antagonists should be avoided because of the increased risk of MIs, because they don't counter the effect of reflex tachycardia. The classes of calcium antagonists include verapamil, diltiazem, and the amlodipine part 1, as discussed earlier. The non-dihydropyridines include verapamil and diltiazem. Verapamil is the least selective of any calcium antagonist and has got significant effects on both cardiac and vascular smooth muscle cells. It is used to treat angina, SVTs, and migraine headaches. Diltiazem, like verapamil, affects both the cardiac and vascular smooth muscle cells. However, it has a less pronounced negative inotropic effect on the heart compared to that of verapamil. So in patients of SVTs and tachycardia, verapamil obviously fares better. Diltiazem would be a better agent if you've got a concomitant coronary going on. The amlodipine part are the new generation calcium antagonist blockers, which are different in pharmacokinetics, and all the dihydropyridines have a much greater affinity for the vascular calcium channels than for the calcium channels in the heart. They are therefore particularly attractive in treating hypertension. The newer agents such as amlodipine have the advantage that they show little interaction with the other cardiovascular drugs such as digoxin or warfarin, which are often used concomitantly with calcium blockers initially and have got problems of heart blocks, etc. So the therapeutic effects of calcium antagonists obviously include that they have an intrinsic natriuretic effect and therefore do not usually require the addition of a diuretic. They are useful in the treatment of hypertensive patients, in patients who are asthmatic, patients who have got diabetes, angina, or peripheral vascular disease, and in the ones who belong to the older age group. So this is a sort of a summary of the various calcium antagonists and their therapeutic indications. So you can use all agents to treat hypertension, including verapamil, diltiazem, and amlodipine. If you've got an angina issue going on, then you would prefer a verapamil and a diltiazem, and amlodipine goes in the later part. In SVTs, obviously, verapamil is a better choice. And if you want to come and you want to use a drug which has got less potential side effects and that is very used to use, it obviously is an amlodipine salt. So then a slide or two on the alpha receptor blockade agents. Prazosin, is a very old agent available in the market. It still is a very wonderful drug which can be used in certain particular indications in which the other agents don't work. And they decrease the peripheral vascular resistance, lower the arterial blood pressure by causing relaxation of both arterial and venous smooth muscle. These drugs cause only minimal changes in cardiac output and renal blood flow and glomerular filtration rate. So therefore, they remain to be a very good agent that can be used in advanced renal failure. Problems with this drug is that it causes posterior hypertension in some individuals and reflex tachycardia, which probably might need to be countered with addition of a beta blocker. Then you've got the benefit of having centrally acting adrenergic drugs available also. Clonidine, the alpha-2 agonist, diminishes central adrenergic outflow. It is used primarily for the treatment of mild to moderate hypertension. that has not responded adequately to treatment with diuretics alone. The side effects of clonidine include mild sedation, drying and nasal of the nasal mucosa, and you should keep in mind that there might be a rebound hypertension that occurs after the abrupt withdrawal of clonidine. Methyl dopaldomate is our favorite salt in pregnant ladies. It's got its own benefit because the alpha-2 agonist converted to this group centrally is basically to diminish the adrenergic outflow from the CNS, leading to reduced total peripheral resistance and a decreased blood pressure. Cardiac output is not decreased and blood flow to vital organs is not diminished. Because blood flow to the kidneys is not diminished, that is why this drug is a favorite choice for us to be used in patients of advanced kidney damage. Problem with this drug is sedation and drowsiness, and any drug which is safe in pregnancy is safe to be used at any stage of hypertension. Then you've got, you should know that hydralazine and minoxidil are also available in the market. You probably might like to use them in various indications. These drugs belong to the group of what is known as vasodilators. Vasodilators produce relaxation of vascular smooth muscles, which decreases resistance and therefore decreases blood pressure. These agents produce reflex stimulation of the heart, and the problems behind them again is that they might have a reflex tachycardia effect, and you need to know that they cannot be very easily prescribed in patients with acute MI or acute coronaries. Hydralazine is used to treat moderately severe hypertension. It is almost always administered in combination with a beta blocker and a diuretic to balance the reflex tachycardia part and to decrease the sodium retention. And hydralazine has got the potential of causing a lupus-like syndrome if used for a longer time. Minoxidil, it causes growth of body hair. So females basically like using this drug because it increases the hair over there. But obviously, you need to make a choice and choose when to use it and not. It causes serious sodium and water retention, leading to volume overload, anemia, and congestive heart failure. So this is a slide that would tell you that if you want to sort of initiate and titrate an antihypertensive drug, you should bring your patient into two groups, basically. A group under the age of 55 years and a person who's above the age of 55 years, based on the logical reason that the patients who are less than 55 years have increased sympathetic drive and increased renin activity, and the ones in which who are comparatively of the older age group, they don't have it. So you can choose between A, B, C. So A stands for ACE inhibitors and Arbs, C is for calcium antagonist, D is for thiazide diuretics, and this has been discussed previously as well. So the various guidelines have shown us the target blood pressure. I don't want to waste any more time on this slide because this has been discussed previously as well. But you all know that when you control blood pressure, it is based on blood pressure threshold and on blood pressure targets, and all the various guidelines of European Society of Cardiology, AHA, JNC have addressed these issues accordingly. The new concepts that need to be kept in mind is that kindly use a wider use of the out-of-the-office blood pressure measurement with the automatic monitoring device or the home monitoring device. And you should have a strategy of educating patients to sort of come up and know about how to control and monitor the blood pressure at their homes in order to achieve the target blood pressure control. So any strategy to control blood pressure begins with an A, that is start one drug, titrate to maximum dose, then add another drug, start one drug, then add a second drug before achieving maximum dose of the initial drug, begin with two drugs at the same time, either as two separate pills or as a single pill combination. So you can enjoy diabetes, high cholesterol, and hypertension, or you can suffer from good health. This is a take-home message for you. And I hope this presentation has helped you realize that the other agents still have got their own role to play, and they can be used at the various stages of hypertension very, very effectively because they have got their own effects. But it is very important to know that they've got a problem of their side effects as well. And there are certain indications in which they need to be used and certain ones in which they need to be avoided. And thank you very much for your patient listening.
Thank you, sir, for this very vibrating kind of presentation. You have covered all of the agents in a very brief period of time. And even though you said that they are forgotten, but we have been bombarded with questions about so many of them. We will be taking them right after this post-test poll. Kindly run the post-test poll. Right. So all participants are requested to kindly register their responses. So Professor Aziz has been answering a lot of questions on your behalf. We will be taking some of them again, but first we will be taking some live questions. Some of our participants have been very patient for the last half an hour, waiting to ask their questions.
Good.
So that is our last question. Okay, so if there are any comments by, right. The first question we are going to take from Dr. Zulfikar Ahmed. I am going to unmute you now. Dr. Zulfikar Ahmed. Dr. Zulfikar, are you with us? Right, Dr. Humaira Said, kindly ask your question. Dr. Altaf Chima, kindly ask your question.
Hello, hello,
Yes, Dr. Altaf Chima, you are audible.
hello.
Yes, please. Please,
Am
Dr. Altaf.
I audible?
Yes, you are audible.
Yeah. My question is that Professor Amir has said that start with a single drug and give the maximum dose, increase the dose to the maximum, and then add the second drug. But during the last few years, we have been listening that it's better to start with a combination if the blood pressure is higher, stage 2 per se. So we can start with the combination.
Let me answer this question. I think, unfortunately, you did not go through all the slides. This was never my message. And in my slides, about 4 or 5 of them, I try to tell you that if the blood pressure is beyond a certain range, then kindly start with a double drug combination rather than choosing a single drug. But if you've got mild hypertension, you can begin with one drug. And your answer is absolutely, your question is absolutely correct in saying that a double drug combination is always better in our circumstances than a single drug combination. You can choose with a single agent. There is no use to go to a higher dosage and then start off with a two drug combination. Two drug combination fares better definitely than a single drug combination. Unfortunately, you probably could not go through with all of my slides. If you could have done it, it answered your question because I never said it. A single drug can be used initially. You have your own patient to decide. There are certain reasons why a single drug can be started.
It was in the last slides. It was in the last few slides. I'm talking about in the last few slides.
Since I'm answering your question, so there is no use of, there is no reason of.
I think the question has been answered. Let's move on to the next question.
I think the message is very clear. Dr. Shaukat and I, we both agree that we should start if patient blood pressure is more than 20 millimeter of systolic and 10 of diastolic, we should start with the combination, and it's preferable to have a single pill combination in such a setting.
It's 20 systolic and 10 diastolic.
Yeah, I said the same. Next
Dr.
question.
Zahoor Ahmed Nazir, do you have any question? Okay, Dr. Maria Jalil. Dr. Maria. Dr. Sanobar. Right, so if we do not have any more questions, live questions, right now, we will be taking some from the chat box. Dr. Talha Munir is asking about the selectivity of bisoprolol and nebivolol beta-1 selectivity. Can they be used in asthma and COPD?
Aziz sahab answer करें. हम तो थके बोल.
So Dr. Somia has joined us.
Then, okay, I can answer. We have to, what exactly, nebivolol versus?
Nebivolol and bisoprolol, the beta-1 selectivity and use in asthma and COPD.
Bisoprolol is cardioselective, about 80%, and it can be used in asthma if needed. But of course, beta blockers are not indispensable in this situation. I think we like to use an alternate agent. But if there is a compelling indication and you want to use bisoprolol, we have to be very cautious because it is selective actually, but this selectivity is relative. Nebivolol is again selective. It is effective for alpha blocker and beta, but as far as beta is concerned, it is selective. So both are relatively safe if there is a compelling indication.
I think I would like to avoid the use of beta blockers if you can, unless there is a compelling indication, and I don't see of any compelling indication. We should try to avoid it as a matter of principle.
If you've got, since we've talked about verapamil and Intazam, what is the compelling indication that you would be sort of using it in patients of asthma? What is the sort of, what would be the compelling indication? I mean, when you've got certain other agents available with you and they've got their beneficial advantages and they're completely safe in asthma, I feel that calcium antagonists, the verapamil one and the diltiazem one, since they effectively control the heart rate, they are very good choices in patients of tachycardia, and they're perfectly safe in asthma. So I believe that in patients of asthma, beta blockers should be basically avoided.
Yes, you are right.
Agreed.
Let me give my view. Although it has been emphasized all these years when we were students and then our career, that beta blockers can precipitate asthma. They of course can, but not in everybody. I have seen people who are asthmatic and are on a beta blocker and they're happy. So I think we need to know that beta blockers can precipitate asthma, but they do not necessarily do so, especially the selective one.
Right.
I actually I agree with Professor Aziz as far as the use of beta blockers, very selective beta blockers in cases with asthma. Now, for example, you have a patient who's asthmatic and has also got congestive heart failure. In such a situation, verapamil and diltiazem should not be used because they do have a negative inotropic action. And it is here that you would be using drugs like carvedilol because they are highly selective. selective and you are able to reduce the heart rate, which is very important. So never use verapamil or diltiazem in patients who are asthmatic and also have congestive heart failure.
In such a setting, the drug of choice will be ivabradine. I think in these sort of people who have got heart failure and you've got tachycardia, you should try to use ivabradine and still try to avoid beta blockers, because at the end of the day, your patient will still be very symptomatic and he actually can become more short of breath because of precipitation of asthma or COPD. So in my sort of understanding, I would like to avoid it. Thank you.
You see, I think I agree with Hafiz when you talk about ivabradine, but do remember that in congestive heart failure, there's an increased sympathetic nervous system activity. And there it is necessary that you use a beta blocker to counter that. And you can go actually with a very small dose of a beta blocker. And if it does not aggravate the asthmatic condition, it becomes quite useful.
I think the beta blockers with the alpha receptor blocking activity, the carvedilol one that was discussed here. One other indication is when you've got a decompensated liver disease with portal hypertension and esophageal varices, and a hepatopulmonary syndrome, or patients of asthma who've got an upper GI bleed problem going with them, then carvedilol again remains to be a preferred agent on top of a calcium antagonist for that particular purpose as well. So one other indication that just came into my mind is that when you've got asthma or a hepatopulmonary syndrome going on along with decompensated liver disease and portal hypertension, and you want to minimize the risk of a rebleed by giving a prophylactic agent, then this agent obviously is a very good tool at hand and can be safely used.
Thank you, sir. So there are several other questions about beta blockers. We will take just one due to constraint of time. Again, by Dr. Talha Munir, the safety of the combination of calcium channel blockers and beta blockers. And he also wants to know, does the timing of both has any role, any effect?
Beta blockers and should I answer this question? Is it addressed to me?
Yeah.
Sir, it is addressed to all the panelists. If Professor Shehbaz Qureshi could please comment, or Professor Abdul Samad, I'm sorry.
Samad sir, would you like to comment?
Sorry, I got
about
the
the combination
presentation
of beta blockers and calcium channel blockers.
Professor Shokat, that he has gone so deep into the management of hypertension with the medications that I missed this question. So if you can repeat the question, I will certainly answer it. I am sorry for
No, sir, it's okay. Sir, right, sir. So the question is about the combination of the safety of a beta blocker and a calcium channel blocker combination, and if the timing of both the agents has to be varied.
Yes, there are calcium channel blockers which have selective effect on the SA node. Those calcium channel blockers who have effect on the SA node, they should not be combined with beta blockers because it can cause severe bradycardia. And I can tell you in my practice, when I was in NICVD, I had at least put 10 or 14, 15 temporary pacemakers in these patients because they have very long pauses. They come into emergency, they have very long pauses. And you know, old man, you should never press the chest very severely because he will have fracture of the ribs. So they have to press the chest because it was severe bradycardia. And we have to put a pacemaker, then stop the. So these are the diltiazem and verapamil. These are the two calcium channel blockers you should never combine with a non-selective beta blocker. I tell you, you will have a very, very severe reaction from this, causing severe bradycardia, but this will not be a bradycardia which will be shown in 1 minute heart rate. Maybe the 1 minute heart rate is about 60 or 55, which is not very bad. This is very good. But you will see that there are pauses coming. Maybe after 2 minutes, you will see a pause, which is about 2 seconds, 3 seconds, 4 seconds. And this I have seen in 14, 15 patients, not in 1, 2. You have to put temporary pacemakers, stop the drugs, and then when the patient comes into, then we write for them. These two drugs should not be combined. Diltiazem, verapamil should not be combined with Introl or with tenormin or drugs like this because they can cause very severe sinus disease. SA nodal block can occur in these patients, so one should
I
avoid it.
think maybe
Amlodipine
the
or nifedipine, with
yeah.
nifedipine or amlodipine, this rule is not because they don't have any effect on the SA node. But I'm saying again this SA node because you know this. There was a time that verapamil and diltiazem was very commonly used, and the blood pressure is not controlled. He goes to another doctor. The doctors are very busy people. There is no question about it. They are very busy. So without asking what medicine are you taking, they say blood pressure is still 150/90. They add a beta blocker. They add the beta blocker. The blood pressure is controlled. The patient comes to emergency room of cardiovascular because the wife says he passed out. इनको होता आ गया उर्दू में ये हमारी जो पास आउट को यहाँ ये कराची वाले जो है ना ये साहिब ज़बान लोग हैं ये कहते हैं ये हमारी मियाँ को गोता आ गया गोता क्या भाई गोता का मतलब है सांस भी बंद हो गया और बेहोश भी हो गया गोते में आदमी सांस बंद करता है ना गोते में आप सांस नहीं ले सकते हैं तो वो आपको वाइफ कहेगी हमारी मियाँ को गोता आ गया दवाई खाई और गोता आ गया जो गोता आ गया अभी गोते से उसको निकालने के लिए टेम्पररी पेसमेकर डालो तो ये कोई आसान काम नहीं है क्योंकि कार्डियो जाना ये वो तो इस वजह से ये दो जो है मैं अगेन स्ट्रेस करता हूँ कि ये अगर मरीज डिल्टाइज़म पे और डिल्टाइज़म के नाम बहुत ज़्यादा हैं आजकल जो है ना कंपनियाँ खुदा का फजल है अच्छी हैं तो मशरूम है तो उसकी वजह से आपको उसका नाम पता चलना चाहिए ये डिल्टाइज़म ले रहा है नहीं ले रहा है या ये वेरापामिल ले रहा है नहीं ले रहा फिर आप बीटा ब्लॉकर ऐड करें वरना अदरवाइज नहीं ऐड करें क्योंकि पेशेंट को साइनस ब्लॉक होगा साइनस ब्लॉक जो है वो होता देता है आदमी को
Right, sir. So we would keep that in mind, and we were coming up with the pre-test and post-test comparison. Professor Amir Shaukat, please
Right.
comment on that. Kindly display the comparison. Thank you.
Right. Which means to say that Professor Hafizullah's message was more concrete and more substantive as compared to answer, unfortunately, is a beta blocker. See, it says anxiety. So when you come across a patient who's got anxiety going on, then beta blockers would fare better than an ACE inhibitor. But Hafizullah Saab's indication
no, I think, Amir, you've done very well. You know, ACE inhibitors reduce from 52 to 40%. So you were able to reduce by 12%, and beta blockers increased from 36 to 40%. So you're the winner, no problem.
Right. But still, beta. See, this is one of those patients in which the patient is not an ideal patient of blood pressure because he doesn't fall into the category of that. If he would have been seen by a psychiatrist and would be on an anti-anxiety drug with a beta blocker, then after 1 month, she would be having a blood pressure of 120/80 and would probably come out of the list of being a That is why I've been saying
Yes, I think ACE inhibitors also have some sympatholytic action.
Good.
No, I think my vote will go for beta blocker in this situation.
Right. Next.
Next, please.
Good. Well done. I'm very fond of this drug. It's very safe in pregnancy, and I have been talking in my presentation that Aldomet, any drug that is safe in pregnancy is safe to be used anywhere in any indication. So,
Sir, I think that's a worthwhile message because methyl dopa has been labeled to be just used in pregnancy. So moving on.
One indication not to be used in is basically autoimmune hemolytic anemia. But that's
and depression. And careful in depression. Perhaps not using depression.
So third question, the comparison for the third question, please.
Very good. A jump from
so
70
the percentage has risen from 70 to 80%. quite significantly.
I only wish you had given a choice of ACE inhibitors as well in this one. That was a trick you did played.
It was done on purpose.
This is Azizur Rahman's tricks that we have to
Yeah.
This was definitely on purpose.
Okay, now coming up with last comparison of the last question.
Wow, this is a good jump, huh? The calcium antagonist that has gone from 60 to 70%. So very good. It's kidney safe, and then a patient who's got a advanced kidney damage going on, and then the benefit of this drug in patients of plus 55 age group. This is obviously a better choice. Excellent, and it's better than methyl dopa.
Sorry, I think I would rather debate it. I think probably ACE inhibitor will be an equally good choice in this sort of a thing, provided you can monitor the renal functions effectively. So I think both agents will be good choice. Calcium channel blocker or ACE inhibitors will be also a good choice in this sort of a setting.
Calcium antagonist needs no.
Professor Hafizullah, I think most clinicians in the real world would probably not use ACE inhibitors or Arbs in this situation. They can be used, but most will probably use immunotherapy.
That's right. This is what I was trying to emphasize, but we somehow the other have learned not, maybe because we have been bitten a few times. I mean, I can see that you use an ACE inhibitor in a patient with a renal problem and perhaps, kidney function deteriorated. So, I mean, but we must remember that the drug which has got most beneficial effect to prevent progression of albuminuria, which goes hand in hand with renal damage in CKD stage 1, in CKD stage 2, up to stage 3. I think we can go along very nicely with this. So if anything good comes out of this talk and out of PSIM, this will be the use of ACE inhibitors and ARBs in renal failure. Thank you.
I think, especially in this situation where a patient has stroke also in the past, the history of stroke, in such a situation, a calcium channel blocker, because that is the one which has shown the best benefit in these patients with hypertension, with recurrent stroke, you put them on calcium channel blockers.
Right, sir. Sir, I would request Professor Abdul Samad Saab to kindly summarize the webinar and give us some take-home messages.
I think very little is left for me to say, because Professor Hafizullah himself, he is a very learned doctor and he has kept himself up to date. Although his hair are graying, but his brain is gray matter more than white matter. So it is opposite his beard. Inside is gray all and outside is white. So he has really done justice to his topic. And Dr. Amir Shaukat has gone so deep into the use of these drugs that I think unless somebody works with him for 6-8 years in his OPD, he may not be able to learn any more from how to manage hypertension. But what I would say is that, I was the first man when I came here, there were 2 drugs in Pakistan for control of blood pressure. One was methyl dopa and one was Inderal. Methyl dopa was MSD and Inderal was ICI. If you can hear me here, these 2 drugs only for blood pressure, no third drug, nothing available for that. The diuretic was Lasix, and if you give Lasix to somebody in tropical areas, he passes so much urine and he is always a lot of sweating. So he gets so upset, he will never return to you. If you give him Lasix 40 milligram and he passes urine 5-6 hours, Dr. Saab, मैं तो इतना कमजोर हो गया, इतना पेशाब मुझे आ गया, मैं तो खत्म हो गया. So we had only choice between methyl dopa and Inderal. Either you start him on Inderal or you start him on methyl dopa. So for pregnancy, as Dr. Amir Shaukat said, no question that you should and must control with methyl dopa. And ACE inhibitors are contraindicated in the early weeks of pregnancy because they can cause genetic defects in the fetus. So they should be avoided in pregnancy. So what now, this is just to give you a past time that when we started the hypertension, then these two drug companies, ICI and MSD, they came to me. One was Zubairi Saab, I remember him, and he was a perfect gentleman. He came to me, and then ICI, I forget because this doctor has gone to Canada. He is in Canada, and sometimes he meets me in the ACC meeting. So they both came to me कि ये डॉक्टर साहब हमारी ये दवाइयाँ ब्लड प्रेशर इतना कॉमन है कोई इस्तेमाल नहीं करता है कोई इस्तेमाल नहीं करता कोई यानी सिर्फ 2 दवाएं अभी 50 दवाइयाँ हैं कितनी यूज़ हो रहा है उस वक्त 2 दवाइयाँ कोई यूज़ नहीं करता है हमने कहा कि हमारे पास तो अगर ब्लड प्रेशर का मरीज आए हम तो इस्तेमाल करते हैं अगर प्रेगनेंसी हो तो अल्डोमेट देते हैं और अगर ये जवान आदमी हो और शादी वादी नहीं हुई हो तो उसको इंडराल दे देते हैं शादी वादी हुई हो तो इंडराल दे दिया तो वो तो आपके साथ लड़ाई के लिए आ जाए क्लिनिक में आप बैठे होंगे आपको गले से पकड़ ले वो आपने हमारा काम ही ख़राब कर दिया डॉक्टर साहब तो वो जो है वो मैंने कहा भाई हमारी तो ये 2 सिलेक्शन है इसी में हम फैसला करते हैं कैसे देते हैं लेकिन खैर उसने कहा कि साहब नहीं सीरियस बात है तो हमने यहाँ पर नॉर्थ नाजिमाबाद से हमने 15 GP डॉक्टर कार्डियोवैस्कुलर में बुलाए और उनको मैंने कहा भाई अपने ब्लड प्रेशर अपरेटस साथ ले आएँ ब्लड प्रेशर अपरेटस साथ ले आएँ क्योंकि मैं चाहता हूँ मैं चेक करूँ आपका ब्लड प्रेशर अपरेटस जो है वो क्योंकि ये की है ब्लड प्रेशर में ब्लड प्रेशर अपरेटस की है जैसे इस्लाम में कलमा की है ब्लड प्रेशर अपरेटस आपका ब्लड प्रेशर हाइपरटेंशन में की है क्योंकि इसी से आप कहते हैं ब्लड प्रेशर है या नहीं है तो वो अपना इक्विपमेंट ले आए आप बताएं 90% ये ब्लड प्रेशर अपरेटस थे उनके जो इन्फ्लेटेबल ट्यूब्स उनका पीछे का जो वहाँ पर वो लगा होता है वो काम नहीं करता था वो हवा उससे निकल जाती थी तो 110 से तो सिस्टोलिक ब्लड प्रेशर ऊपर जाता ही नहीं था यूं ही आप उसको इन्फ्लेट करेंगे 120 पे पहुंचेगा पीछे से हवा निकलनी शुरू हो जाएगी और ब्लड प्रेशर पारा जो है नीचे आ गया 80% ये जो 15 और नॉर्थ नाजिमाबाद जो है ये बड़े पढ़े लिखे लोगों का इलाका है मेरे ख्याल में यहाँ 95% एजुकेटेड लोग रहते हैं मैं भाई इनका जो GPs का हाल है तो ये बाकी क्या हाल होगा तो मैंने इनके साथ ये गए मैंने भाई ये तो बड़ी ही मायूसी की बात है कि ब्लड प्रेशर पाकिस्तान में कोई मेजर नहीं कर सकता है क्योंकि GPs ही करते हैं तो आप ऐसे करें इनको ब्लड प्रेशर अपरेटस दे दें एक स्टेथोस्कोप दे दें एक ब्लड प्रेशर अपरेटस दे दें इन्होंने यहाँ पर जो है नॉर्थ नाजिमाबाद में 200 ब्लड प्रेशर अपरेटस और 200 स्टेथोस्कोप सब डॉक्टरों को मेथड सबको आता है लेकिन अपरेटस काम नहीं करता और वो शर्म के मारे बोलते भी नहीं है कि भाई ये काम ख़राब है इसका इतने बिजी हैं 300 तो मरीज देखता है वो इसके बाद हमने हैदराबाद में इस तरह ब्लड प्रेशर अपरेटस तकसीम की तो इसलिए एक बात जो मैं आपको बताता हूं कि आप जो जब कभी बाहर मुल्कों में जाएं नया ब्लड प्रेशर अपरेटस लाकर अपने टेबल पर रख दिया करें ये जो आपका इन्वेस्टमेंट है मैं कहता हूं अल्लाह ताला आपको क़यामत के दिन इसकी बदला ज़रूर देगा इसका बदला आपको ज़रूर मिलेगा क्योंकि ब्लड प्रेशर बड़े बेस्ट ब्लड प्रेशर अपरेटस के नहीं हो सकता मैं आपको बताऊं मेरे ब्लड प्रेशर के बहुत सारी मरीज इसलिए आते हैं कि मैंने एक ब्लड प्रेशर अपरेटस ख़रीदा है एक यहूदी सप्लायर से न्यूयॉर्क में उसने उसके ऊपर लिखा है $240 ऊपर लिखा वो पर्ची लगी हुई है $240 की पर्ची लगी मैंने यानी जानबूझ के नहीं लेकिन मैंने गलती से वो हटाई तो मरीज जब देखता है ये तो $250 का तो अपरेटस है भाई वो दूसरे डॉक्टर के पास जाता हूँ तो 50 रुपए के ब्लड प्रेशर अपरेटस से मेरा BP चेक करता है पता नहीं सही भी होता है सही नहीं अक्सर आते हैं मेरे लड़के से कहते हैं नहीं भाई वो $250 वाले से मेरा ब्लड प्रेशर चेक करा दो मेरा कहने का मतलब ये है कि भाई ब्लड प्रेशर अपरेटस लेटेस्ट होना चाहिए उसको आपको चेक करना चाहिए और सही होना चाहिए अदरवाइज ये आपकी जो रीडिंग है ये सारी गलत रीडिंग है सब बेकार रीडिंग है जो हमने इतनी तकरीरें की इनका फ़ायदा नहीं है जब तक आपको एक्यूरेट रीडिंग होनी चाहिए अच्छा दूसरी बात जो मैं कहने वाला था وہ یہ ہے کہ یہ لیفٹ وینٹریکولر ہائپرٹروفی ہے, یہ ہارٹ فیلئر ہے, ڈائسٹالک ہے, اور یہ ہے وہ. لیکن ایٹریل فبریلیشن آپ کو بھولنا نہیں چاہیے. ابھی ہمارا جو پاپولیشن پاکستان کا ہے نا, یہ میں آپ کو کہتا ہوں, یہ آج سے 30 سال پہلے پاکستانی پاپولیشن نہیں ہے. ابھی یہاں ایجڈ پاپولیشن بڑھ گئی ہے, ایجڈ پاپولیشن بڑھ گئی ہے. آپ کا کلینک میں دیکھیں 60 سال سے اوپر بہت سارے مریض آئے ہیں. اور ایٹریل فبریلیشن جو ہے یہ بالکل ایج ریلیٹڈ ڈیزیز ہے, ایج ریلیٹڈ. تو آپ کے پریکٹس میں ایٹریل فبریلیشن بتائیں گے. آپ بے شک بلڈ پریشر کنٹرول کریں. اگر اے ایف میں آپ نے اس کو اینٹی کویگولینٹ نہیں دیا, وہ اسٹروک لے کر آئے گا لازمی. اس کو 1-2 سال میں اسٹروک ہوگا اس کو. اس لیے اے ایف کو آپ کو ڈسکور کرنا چاہیے, اس کو ٹریٹ کرنا چاہیے, پریونٹ کرنا چاہیے. ایک تو اس کا میں نے کہا کہ اس لیکچر میں آپ کو بتاؤں کہ ایٹریل فبریلیشن بہت کامن ہو رہا ہے, اور اس کو آپ کو مینیج کرنا چاہیے اینٹی کویگولیشن. اور تیسری بات یہ ہے کہ الفا بلاکر کے متعلق آپ کو ایک لطیفہ بنا کے پھر میں آپ کو چھوڑ دیتا ہوں. ہمارے پاس ایک پیشنٹ آیا, بہت زمانہ ہو گیا. اس زمانے میں ہم مریضوں کے ساتھ بہت باتیں کریں, مریض کم ہوتے تھے تو مریض ہمارے ساتھ بہت باتیں کرے. بھائی مریض جو ہے نا, یہ آپ کے ویٹنگ روم کو دیکھتا ہے, یا وہاں مریض زیادہ ہوتے ہیں, یہ آپ کو کام کی باتیں کرتا ہے. یہ آپ کے ساتھ کیا کام کرتا ہے, کام کی بات کرتا ہے. جب دیکھتا ہے بھائی مریض کم, آپ کے ساتھ جو ہے نا یہ غیبت شروع کر لے. آپ نے جو 2-4 نمازیں پڑھی ہیں وہ کسی اور ڈاکٹر کے اس میں چلی جاتی ہیں, تو یہ آپ کے ساتھ ادھر ادھر کی باتیں کر. اس زمانے میں ہماری ویٹنگ روم میں کم مریض ہوتے تھے, تو یہ آ کے ہمارے ساتھ گپ شپ بہت لگائے تھے. ایک مریض آیا ہائپر ٹینشن کا, اس نے اتنی باتیں کی, میں آپ کو بتاؤں کہ میں اگر خدا رسول سے نہ ڈرتا کہ بھائی اس نے فیس دیا, اس کی باتیں سنو, اس نے مجھے پریشان کر دی. اتنی باتیں اس شخص نے مجھے بتائیں, ڈاکٹری کی باتیں بتائیں, مذہبی بتائیں, سیاسی بتائیں, یہ وہ یہ فلانا پیر و فقیر و سب باتیں بتا کے میں نے ساری سن لی. میں نے اس کی بیوی سے کہا ان کو تکلیف کیا ہے. بیگم صاحب نے کہا ڈاکٹر صاحب ان کا بلڈ پریشر کنٹرول نہیں ہوتا ہے. یہ ساری ہسٹری اتنی, بلڈ پریشر کنٹرول نہیں ہوتا, ہر قسم کی دوائی انہوں نے کھا لی لیکن بلڈ پریشر نہیں. اس میں نے دوائی دکھا, اس نے ٹیبل کے اوپر تقریباً اس زمانے کی 4-5 دوائیاں ساری رکھی. ڈائیوریٹک بھی لے رہا تھا, الڈومیٹ بھی لے, انڈرال بھی لے رہا تھا. اب یہ جو پرازوسین ہے یہ نئی آئی ہوئی تھی, لیکن اس کا میں آپ کو بتاؤں اس میں فرسٹ ڈوز رسپانس ہوتا ہے. اس مریض کا قصہ اس لیے سناتا ہوں کہ آپ بھول نہ جائیں. اس کو میں نے پرازوسین 2 ملی گرام لکھ کے دی, اور میں نے صرف کہا بھائی آپ یہ دوائی جو ہے یہ صبح ناشتہ کر کے اس کے بعد لیں, پھر باتھ روم نہیں جائیں. پھر باتھ روم اس کے لینے کے بعد باتھ روم نہیں جائیں, پہلے باتھ روم چلے جائیں, بلیڈر خالی کریں, پھر دوائی لے لیں. اس کے بعد 2-3 گھنٹے تک اٹھی نہیں. اگر اٹھیں تو بیوی سے کہیں کہ آپ کو ہاتھ سے پکڑ کے وہاں لے لیں. کیوں؟ میں نے کبھی کبھی اس کے بعد آتا ہے, کبھی کبھی چکر آتا ہے. چکر کیوں آتا ہے؟ میں نے کبھی بلڈ پریشر کم کر, ارے ڈاکٹر صاحب تو اتنی دوائی کھائی ہے, میرا بلڈ پریشر کبھی بھی 190 سے کم ہوا ہی نہیں ہے. میں نے بہت ڈاکٹروں سے چیک کیا, یہ کیسی دوائی ہے میرا پریشر کم. میں نے کہا دیکھیں آپ کو جو میں بولتا ہوں اس پہ آپ یقین کر لیں. آپ میرے پاس آئے ہیں, اپنی مرضی سے آئے ہیں, آپ دوائی کھا لیں, لیکن صبح ناشتہ کریں, اس کے بعد دوائی کھائیں, پھر باتھ روم جو ہے وہ خیال سے جائیں. نہ جائیں تو اچھا ہے. خیر یہ کسی اور ڈاکٹر کے پاس گیا ہوا ہے, اس نے اس کو کہا بھائی جو بلڈ پریشر کی گولی جو ہے یہ رات کو کھانی چاہیے, کیونکہ رات کو آدمی سوتا ہے نا, بلڈ پریشر بہت بڑھ جاتا ہے تو اس کو اسٹروک ہو جاتا ہے, پتہ چلتا نہیں. اس لیے بلڈ پریشر کی گولی رات کو کھانی چاہیے. دن کو تو سر میں درد ہو جائے گا, بلڈ پریشر چیک ہو جائے گا. اس نے رات کو یہ گولی کھا لی. یہ قصہ آپ سنیے, بہت ہی پرازوسین 2 ملی گرام رات ہوتے وقت اس نے کھا لی. رات 12 بجے اس کو پیشاب آ گیا, کیونکہ نارملی ایک دفعہ تو انسان پیشاب کی لوٹتا ہے. وہ باتھ روم گیا. اچھا وہ کرائے کے مکان میں رہتا تھا, کرائے کے مکان والے نے انگریزی ٹوائلٹ بنایا ہوا تھا. یہ اس میں پاکستانی طریقے سے بیٹھتا تھا, یہ اس کے اوپر اسکواٹنگ کرتا تھا, یعنی وہ انگریزی ٹوائلٹ کے اوپر ایک پاؤں ادھر ایک پاؤں ادھر یہ بیٹھا رہتا, اسی سے یہ پیشاب کرتا. اب جب اس نے فرسٹ افیکٹ ہوا اس کو جو چکر آئے, گرا ہے, اس کے 2 دانت ٹوٹ گئے. ادھر سے جو گرا ہے سامنے, بھائی ادھر بیٹھا ہوا تھا نا, آپ اس کو امیجن کریں, وہ انگریزی ٹوائلٹ کے اوپر پاؤں کے ساتھ بیٹھا ہوا تھا. کوئی چیز پکڑی وکڑی تو تھی نہیں, ایسے ہی بیٹھا ہوا تھا. جب چکر آئے نیچے گرا, 2 دانت اس کے टूट गए, ये जो है बीवी इसको इमरजेंसी में ले गए, उन्होंने कहा इसका तो बीपी बहुत लो है भाई, इसका तो ब्लड प्रेशर जो है 90 और 60 है। उसने कहा नहीं नहीं आपका ये ठीक नहीं है, अरे तुम जना अस्पताल वालों जो है ना सारा बजट खा जाते हो, ये है वो है। मेरा ब्लड प्रेशर कभी 190, उन्होंने कहा अरे भाई दूसरा ले आओ, दूसरे तीसरे उसका बीपी हुई। फर्स्ट जो इफेक्ट जो इन्होंने कहा है, मैंने कहा इसको मैं ज़रा आपको हाईलाइट करूँ, इसका मतलब क्या होता है। वो 90-60 उसका ब्लड प्रेशर, ड्रिप विप लगाया, बंदा कुछ ठीक हो गया। ये 1 महीने के बाद आ गया, इसके बाद इसका बीपी उससे प्राइवेसी से कंट्रोल रहा, लेकिन उसके 2 दांत टूट गए और इसके बाद डेंटिस्ट के पास जाके उसने दांत ठीक करा। ये मेरे पास आया, मुझे इसने सारा किस्सा सुनाया। आपने डॉक्टर साहब बात की थी लेकिन मुझे समझ नहीं आई थी उसकी, तो मैंने ये काम किया, मेरे 2 दांत टूटे। तो बीवी ने कहा डॉक्टर साहब अच्छा इनके 2 बहुत ख़राब लगते थे, बड़े बड़े दांत निकले हुए थे, अच्छा टूट गए, अभी इसने डेंटिस्ट से ठीक करा दी। इसलिए ये कहता हूँ कि जो अल्फ़ा ब्लॉकर्स हैं, इसकी तो एक ये है कि हार्ट फेलियर में मोर्टेलिटी बढ़ाते हैं। इसकी जो है पॉजिटिव स्टडीज़ मौजूद हैं कि अल्फ़ा ब्लॉकर हार्ट फेलियर में मोर्टेलिटी बढ़ाने वाली ड्रग हैं, इस वजह से अल्फ़ा ब्लॉकर से दूर रहें हार्ट फेलियर पेशेंट। दूसरा ये है कि फर्स्ट डोज इफेक्ट मरीज़ को जैसे मैंने समझाया वैसे ही समझाएं। अगर मैं न समझाता ये आके मेरे साथ लड़ाई करता कि आपने ऐसी दवाई दी, मेरी तो 2 दांत टूट गए। लेकिन चूंकि मैंने बड़े ख्याल से इसको ये फर्स्ट डोज इफेक्ट का कहा था, तो सारी बातें जो है ना मुख्तसर बातें हैं कि जो बात कर रहा हूँ कि नॉर्मल ब्लड प्रेशर, लेकिन नॉर्मल ब्लड प्रेशर पर बड़ी लड़ाई है। इसके अंदर सर देना जो है ना ये मेरे लिए मुनासिब नहीं इस ओल्ड एज में, लेकिन फिर भी मैं आपको बता देता हूँ जो मेरी अपना ख्याल है। ब्लड प्रेशर नॉर्मल 120/80 है, नॉर्मल ब्लड प्रेशर 120/80 है। ये हमें डॉक्टर अलामदार हुसैन साहब हमारी फिजियोलॉजी के प्रोफेसर थे किंग एडवर्ड मेडिकल कॉलेज में, उन्होंने हमको ये बात बताई थी। और मैं कहता हूँ उस शख्स की बात में पत्थर की लकीर है। आज तक जितना मैंने लिटरेचर पढ़ा है किसी ने इसको गलत नहीं साबित किया कि नॉर्मल ब्लड प्रेशर होता है 120/80। हालात के मुताबिक और आर्गन डैमेज फलाना ये वो ये बातें सब हैं, लेकिन ये याद रखें नॉर्मल ब्लड प्रेशर 120/80 के मरीज जो है।
Thank you for sharing your experiences. I am extremely sorry to interrupt you. But we have already run over the time. Thank you so much for being with us today. And before I conclude this session, we have been joined by General Secretary PSIM, Dr. Somia Iqtidar. She has a message for all of the participants and the panelists. Dr. Somia, please.
Thank you very much, Sidra, and 2 very wonderful, powerful speakers we had today, Professor Muhammad Hafizullah and Professor Amir Shaukat. I could not attend the whole session because I was traveling, but the little bits in which I connected, I saw a lot of knowledge being poured out to the audience. So thank you very much to both of you for being with us today, and Professor Abdul Samad for sharing his interesting life experiences with us. I have just one small announcement for all the participants that we are holding our 2nd annual conference on 30th and 31st of July and 1st of August in Islamabad this year. You can all register for this conference, and there are a lot of pre-conference workshops, and there is Pakistan Society of Internal Medicine Research Award as well, which is going to happen in this conference. The last date of abstract submission is 25th of June. So those of you who have not already submitted your abstracts for the competition, you can, because we have extended the date by 5 days. And the registration link is open. Those of you who have already registered, because we had to postpone the Karachi conference, the registration is still valid, and hope to see all of you there. Thank you very much, Professor Azizur Rahman. We missed you at the Rawalpindi launch because we just launched our Rawalpindi chapter last evening, and he could not join because of this commitment, and this shows his dedication to this course. Thank you very much, everyone, and have a very good evening. Allah Hafiz.
Thank you, madam, for your message. I hope we would be seeing many of you at the PSIM annual conference. I would like to thank our chair for today, Professor Abdul Samad, our speakers, Professor Muhammad Hafizullah Khan, Professor Amir Shaukat, and our panelists, Professor Azizur Rahman Sahab, without whom these sessions would not be possible, Professor Shahbaz Qureshi for consistently joining in on the course. Professor, we were also joined in by Professor Tariq Wasim and Professor Sajid Ubaidullah briefly. I think they are also traveling. And thank you, Dr. Somia. In the end, this activity would not be possible without our corporate partner at Laboratories. And we have been joined today by Mr. Kashif Riaz and Mr. Akhtar Tahir. Thank you very much. And I hope that we would be collaborating for these educational activities in future as well. Before signing off for today, I would like to announce the topics, the activity for the next Sunday. The session will be chaired by Professor Muhammad Akbar Chaudhary and moderated by Dr. Mehreen Farooq. There will be two modules, and the speakers will be Dr. Somia Iqtidar. She will be giving an overview of the hypertension-mediated organ damage, and Professor Anthony Hegarty, he will be talking about hypertension management. With that, I thank you all for your patience and your participation, and we hope to see you next week.
Sorry, just to interrupt you, Sidra. Professor Anthony Hegarty, he had to skip this program. We will take him on some other session. Next time will be Professor Thomas Unger, and the topic remains the same, the hypertension management.
Thank you, madam. Thank you for the
Okay, and Allah Hafiz.
Allah Hafiz, everybody. Thank you very much.